Yeah, so far there's been a lot of interesting results. The Danish ICD trial did not show benefit in the non-ischemic cardiomyopathy patients with survival. The Antarctic trial showed that platelet monitoring in the elderly patients following PCI didn't really make a difference. The SAVE trial showed that the CPAP therapy and sleep apnea didn't make a big difference. A big trial from pitavastatin and ezetimibe showed that ezetimibe did not produce additional lowering in events when added to pitavastatin. A cardiac rehab trial showed that more intensive cardiac rehab had some benefits but didn't change the primary endpoint. So really so far there's been a lot of negative studies, but I think it's showing that it's hard to improve on the very vigorous therapy that we've given to so many of the cardiovascular disease patients in 2016. I think right now the standards are high. We have a lot of proven therapies, and many people are receiving optimal medical therapy. And probably those who get into a trial are receiving more vigorous therapy than many of the patients who are not in the trial. So it's quite possible that some of these interventions may have been more positive in some of the patients who didn't get into the trial than those who are getting into it. But really, we've had a lot of negative studies. I make decisions based on, I'm more of a preventive cardiologist, so I'm obviously going to be picking things that are more into prevention, lipids, and other aspects of prevention, cardiac rehabilitation. I'm also editor of a journal, Progress in Cardiovascular Disease, and so I do want to get a feel of some of the other topics because I'm also involved with other topics other than my main specialty because of my journal. Well, I'm doing a big gladiator session in a couple of hours that is talking about is exercise more is more better, and I'm actually taking that more is not better. And we've actually published a lot on, of course, the benefits of exercise, but that it seems like the benefits of exercise are occurring at quite low doses. Another abstract that I'm presenting with a group from Norway is assessing the impact of physical activity on the obesity paradox. I've probably published the most in the world on the obesity paradox in cardiovascular disease, and I have a book called The Obesity Paradox. But we showed in this paper in a large cohort that physical activity markedly alters the relationship. If you're physically active, it really didn't matter what you weighed, whereas there was more of an obesity paradox in the non-physically active people. Well, I think they do, because certainly the people that go to them, take information back. But obviously, there's a lot of people that don't make these meetings, but they're getting the media reports. There's a lot of media reports coming out every day, and obviously the top studies get published in the top journals like New England Journal of Medicine, JAMA, Lancet, European Heart Journal, and then there's press releases for all those top stories. So I think that the results disseminate to the clinical cardiologists who, again, the majority in the world are not at this meeting, but it also disseminates to patients. I mean, patients get the information too from these meetings, at least the major highlights. I think that this is in a way over the head for most medical students. The only thing that a medical student could get out of this is the excitement of what's going on in the field. The problem with a medical student, though, is that a medical student would probably be better going to a general medical conference or family practice conference than cardiovascular diseases. Now, of the medical subspecialties, cardiovascular disease is probably the most important because probably half of general practice and internal medicine involves cardiovascular topics. But I do think this is a little bit beyond the medical student. unless a medical student is already thinking of, they've got a high interest in cardiovascular diseases. I really think right now that the key message is that we're doing very well with optimal medical therapy, and that it's pretty hard to improve on that, because most of the trials that are being presented have come out negative. And some of them are because they're underpowered or they weren't long enough. But a lot of times it's because the control group is so well treated. Certainly, I would think that some genetic therapies are going to make a big progress, and therapies with monoclonal antibodies are going to make progress in not only cardiovascular diseases, but many diseases, cancer and rheumatologic diseases and many other things. And I think it still will be an exciting time. Again, the more medicine advances, it's hard to make the next level of advance, but there's still a lot of exciting things happening that take a while to make it to the clinical arena. Well, in cardiovascular diseases, probably the most exciting things are, I think, the percutaneous valve therapies. I'm a preventive cardiologist, so that's not my particular thing, but I think the TAVR and the mitral clip procedures are really going to make big advances. They're going to end up leading many patients that are going to be able to be treated percutaneously as opposed to open chest surgery. The other big thing, I think, is the PCSK9 inhibitors, the drugs that are going to be added to statins and probably produce close to 60% reductions in LDL cholesterol and probably very big reductions in cardiovascular disease events. A lot of people misinterpret and my research and my book and some of my statements, and they think that I'm trying to say that obesity is a good thing. The thing that I'm actually trying to show is that weight has really increased in many areas of the world, and there's been an obesity epidemic throughout the world. We have a big problem in the United States, but a lot of Western world has obesity, and even really most of society has increasing obesity, probably because of significant reductions over decades in physical activity. But the major thing that I want to show is that it's not doomsday if somebody's carrying some extra pounds, and that fitness is much more important than fatness with regard to long-term outcomes. In fact, a thin person who's not fit has a worse prognosis than a heavy person who has a high level of fitness. So again, fitness beats fatness, and we should be putting more emphasis on improving fitness, and the way to improve fitness is with regular physical activity and exercise training. And with regular physical activity, obviously you would prevent the obesity in the first place, but physical activity leads to the increased fitness. And that's probably one of the strongest predictors of prognosis and survival of all of our cardiovascular risk factors. The thing that I want to really emphasize is that mild overweightness or a little bit obesity is not the end of the world, that you can still have a very good prognosis carrying extra weight, particularly if you're fit, and even more so if you're fit and metabolically healthy. That would be number one. Number two is, no matter what the weight is of someone today, the most important thing is preventing progressive weight gain over years, and the way to do that is with regular physical activity. In fact, if everyone was physically active from a young age to adulthood, we'd probably not have so much overweightness and obesity. What's a big scare for us in the United States, and I don't think it's quite as much in Europe yet, but not only do we have something like a 37–38% prevalence of obesity, we have an 8% prevalence of severe obesity, which is BMIs over 40. And that's been increasing more so than obesity per se, and that is dangerous. Now, I emphasize that overweightness and mild obesity, people can do very well, especially if they're fit. It's pretty hard to be fit if you're carrying 100 extra pounds. And those people are in big trouble. And that's been increasing, and we certainly need to make efforts to have that prevented, but also to have it treated, maybe even with bariatric surgery in many people. Certainly, I mean, bariatric surgery is targeting it. It's a shame that it's degenerated to that level, because the way to really target it is to target it at an early stage and to prevent it in the first place. And that could happen with increasing physical activity throughout the healthcare system, throughout our society. And it has to happen in school-age kids, because what's really scary too is that, I'm 57 years old, and when I was a kid, everyone was outside playing. They were out all day in the summers after school. Now the kids are playing on their phones, playing video games, on the computer, watching TV, and unless they're involved in formal sports, they're not nearly as physically active as they were many decades ago. And so not only do we have the adults dropping their occupational physical activity and their household management physical activity, because with industrialization, people don't have to do as much work. Well, now the kids aren't doing physical activity too. And so we're seeing overweightness and obesity even in kids. And so if a 15-year-old is already heavy, I'm very concerned that they could be in big trouble when they're in their 40s and 50s, because they're probably going to be pushing or staring at the severe obesity, which is certainly not a benign thing. Well, certainly we have so many medications. It's picking which ones have the most evidence and the most cost effectiveness. It's also, in the United States, I think we're dealing with this more than in Europe. It's also the cost of the therapies. For example, the PCSK9 inhibitors appear to be extremely good medications to lower LDL cholesterol by close to 60%, and it looks like they might be lowering clinical events by close to 50% in at least the initial studies, which were not designed for clinical event reduction. But they also are costing $14,000 per year, and the healthcare system can't afford that. And again, I think here there is more a managed healthcare system, and it's more government-run healthcare. But I don't think the governments are going to be able to handle that kind of cost. And maybe it's a little bit less expensive in Europe than it is in the United States, but still, this is an expensive therapy. And so, dealing with the cost of therapies, and then the other thing is dealing with the electronic medical records for many types of physicians, and certainly physicians in cardiovascular diseases. Certainly that's been a tremendous advance for taking care of big populations, but it's got a downside too. Physicians are burning out because they're attached to the electronic medical record every minute of every day, and the workload has massively increased. The expectations are higher, and many physicians are not enjoying the fact that they feel like they're data entry people, as opposed to really taking care of the patient. They're spending more time with the computer than with the patient, and that's something that is a potential problem that there's no easy solution for, because we're certainly not going to go back to the non-digital age. But something needs to be something needs to happen to decrease the amount of physician computer time and increase the amount of face-to-face interaction with patients.